Thank you for being part of the audience today. My name is Astrid Robin Van Aggelen. I am a veterinarian and I have been employed at KCA for a bit over 18 months. Today, I want to talk about the clinical management of chlamydiosis in koalas from a veterinarian perspective. Unfortunately, today for you, I have more questions than answers and more failure stories than success stories to share. So let's start with a brief overview of Chlamydia pecorum, the causative agent of chlamydiosis in koalas. It exists under different forms: a free infectious form, an intracellular form, which is responsible for the multiplication of the bacteria, and a latent form where the bacteria can stay dormant in the host cells until reactivation. It is a natural inhabitant of the digestive tract of cattle and sheep, and sometimes pigs. It usually is asymptomatic in these species, even though it can cause subclinical disease with no overt signs other than decreased fertility and weight gain. But it can also sometimes cause clinical disease such as conjunctivitis, respiratory symptoms, diarrhea, arthritis, and encephalomyelitis. In this species, the mode of transmission is unknown, but it is highly suspected to be transmitted via the fecal-oral route, possibly inhalation and possibly sexually. In koalas, we know little about the mode of transmission. It is thought to be mainly transmitted sexually, but also possibly from mother to joey via papping. We don't know if the disease is transmitted through other forms of direct contact, in utero, via birth fluids or milk. We don't understand the environmental reservoirs, even though it is thought that the disease spilled over from cattle to koalas through the ingestion of contaminated dirt. And we don't know if the disease can be transmitted via vectors. We also don't understand well the physiopathology of the disease. We don't know if it is a systemic disease or if it is localized to some organs only. And we don't know if the infection is always going to evolve in disease and how long this will take. So the bacteria can affect the conjunctiva, causing proliferative conjunctivitis. It can also affect the urinary tract, which can take the form of wet bottom, which is the result of cystitis. And it can also cause kidney disease. It can also infect the genital tract, which can take the form of orchitis, paraovarian cyst, pyometra, and cause infertility. The clinical presentation can be one or a mix of these different clinical signs, and asymptomatic infections are also common. The treatment options are limited. Many antibiotics are either ineffective at treating the bacteria or very effective at killing the koalas. This leaves us with few options: either doxycycline weekly injections for 2 to 4 weeks or chloramphenicol daily injections for 2 to 4 weeks, with the caveat that chloramphenicol can be hard to source. These two antibiotics are not as quick at killing koalas, but they will eventually lead to deadly dysbiosis if used for a prolonged period of time. Ocular antibiotic ointment is also available, and pain relief and anti-inflammatories are administered as needed. So now I want to present a series of clinical cases, starting with Burrawan St Gerry, who was a 45-year-old male who was admitted for dog attack. He had minor injuries and weighed 8.1 kilos with a good body condition of 7 out of 10. He had no clinical signs of chlamydiosis, but his chlamydia PCR test came back positive on the urogenital swabs, but was negative on ocular swabs. He received 2 injections of doxycycline a week apart, and he literally crashed a couple of days after the second injection. We literally tried to keep him alive for the following 5 weeks, time during which he developed a wet bottom grade 1 out of 7. He eventually died despite our best effort. He had lost 1 kilo, and his swabs taken on death showed that he was positive both for ocular and urogenital swabs. The second clinical case is Armidale Oliver, which was an 8-year-old male. He was admitted with a bilateral proliferative conjunctivitis, grade 9 out of 9, a body condition of 6 out of 10, weighing 8.4 kilos. He did not have any wet bottoms, and his chlamydia PCR test came back positive both on ocular and urogenital swabs. He received 3 injections of doxycycline a week apart, and his clinical symptoms resolved, even though he kept a mild persistent proliferative tissue on his conjunctiva. and his PCR test came back negative on urogenital and ocular swabs. So usually this is the point in time where I release koalas, but because he had lost so much weight, wanted to keep him longer and sort of build him up. A few weeks later, he developed clear ocular discharge, a wet bottom grade 3 out of 7, and his chlamydia PCR test came back positive for his urogenital swab and remained negative on his ocular swab, despite the fact that he developed ocular symptoms. And he eventually died, despite our best efforts again, with a body condition of 2 out of 10 and weighing 6.8 kilos. The last clinical case that I want to talk about is Crestwood Dr Suzie. So she's an aged female and she was admitted last year in March with no other clinical signs, but she had a thickened bladder and a small unilateral perovarian cyst on ultrasound. And her urogenital chlamydia PCR test was positive. So she was treated with 2 injections of doxycycline and retested. The test came back positive, so she received another course of 2 weeks of doxycycline. She was retested and tested positive again, so she had a 3rd course of 2 weeks of doxycycline. She tested negative, and so she was released in September. She was randomly caught in April this year for a research project. She had no clinical signs, but on ultrasound she had, once again, a thickened bladder, and this time bilateral perovarian cyst, and she tested positive on her urogenital swab as well for chlamydia. So I chose to present these cases because they illustrate well the challenges that veterinarians face when treating chlamydia. And the first major challenge is dysbiosis. It is a common side effect of antimicrobial treatments. Koalas are high gut fermenters and they heavily rely on their gut microbiome to digest their food. Antimicrobials can affect the microbiome and can cause deadly dysbiosis. I found reports of dysbiosis in publications from the 1960s. More than 50 years that we lose koalas to dysbiosis, and that dysbiosis limits our treatment options. But despite this, we barely have any understanding of the physiopathology of dysbiosis. We have next to no knowledge on how to effectively support the gut microbiome, and we have no available supplements or medications that can support this microbiome. And because of this side effect, which can be so severe and will occur with prolonged antibiotic treatments, we try to keep our antibiotic courses as short as possible. The second major challenge is that due to the biology of chlamydia, and as illustrated by these clinical cases, a negative PCR test is an indication of absence of shedding, but it does not confirm bacterial clearance. So these observations have led me to question whether the current standards for the clinical management of chlamydiosis are achieving the desired outcomes, and actually wonder what is it that we are trying to achieve. And so the first question that I have is, are we actually successfully achieving bacterial clearance with the current standard treatment regimens? Unfortunately, we have no long-term temporal studies, no means to differentiate a new infection versus a relapse when a koala is readmitted with a chlamydial infection. And dysbiosis is such a limiting factor, stopping us from treating koalas for extended periods of time. And when doing a quick comparison of the treatment of chlamydiosis in other species, this is what I found. In humans, patients with symptoms and their sexual partners are treated, but asymptomatic patients are not treated. Ocular disease is treated with 6 weeks of topical ointment or oral antibiotics. And the urogenital form of the disease can be treated with different molecules, but when it comes to doxycycline, the treatment ranges from 1 to 3 weeks, and relapse of symptoms have been observed in up to 25% of cases, depending on the study. In cats, the treatment is doxycycline 4 to 6 weeks, and it was shown that treatments of less than 21 days led to the resolution of clinical sign and absence of PCR detection of the bacteria, but the disease recurred after treatment with increased clinical signs and bacterial loads. In birds, the treatment is doxycycline for 4 to 6 weeks as well. In pigs, fun fact, tetracycline resistance genes have been identified. The prevalence of Chlamydia suis is above 90% in the GI tract, and mixed infections of Chlamydia suis and Chlamydia pecorum are common. and mostly asymptomatic. Only symptomatic animals are treated, and antimicrobials do not clear the infection at a herd level. Similarly, in ruminants, only symptomatic animals are treated, and the conclusion that I found in the review was that antibiotics inhibit the growth and reduce losses, but do not eliminate the bacteria, and affected animals continue to shed the organisms. So, in light of these observations, one may ask, how should koalas be treated? Because of the risk of dysbiosis, and as we do not know if the disease is localized or systemic, some veterinarians will elect to treat conjunctival disease with topical ointment only. But what if the disease is actually systemic? And if so, how long should we treat with systemic antibiotics to induce complete bacterial clearance? But can bacterial clearance actually be achieved? Is it desirable to achieve bacterial clearance, or should we aim to reduce the bacterial load only, hoping that the immune system will do the rest? On the contrary, will the disease eventually reoccur no matter what if bacterial clearance is not achieved? Which animals should we treat? Should we treat all positive animals or just the symptomatic ones? And what should we do with the asymptomatic ones? Should we treat them, potentially exposing them to deadly dysbiosis because they will eventually develop the disease anyway? And because as they are the healthiest, they are more likely to respond well to treatment? Or on the contrary, is there a chance that they will clear the infection by themselves and potentially become more resistant to the infection and pass on this resistance to the population, hence supporting a natural selection of chlamydia-resistant animals? How can we prevent the transmission of the disease in the first place? We can't really answer this question if we don't understand both the modes of transmission and the reservoirs. And the medical management of populations will be completely different depending if your transmission is indirect or direct, and depending on where your reservoirs are. And so we can't really take effective measures if we don't understand where we sit on these spectrums. Lastly, what is it that we're trying to achieve? What is our end goal? Are we aiming for the eradication of the disease, or do we want or have no other option but to maintain a certain level of infectious pressure amongst wild populations? The bottom line question is, what is our strategic plan? So since I started working at KC 18 months ago, I have admitted 74 koalas infected with chlamydia. So far, 6 are still in care, 13 have been released, and 55 have died as a result of advanced disease or side effects of treatment. A shameful 75% of koalas admitted with a chlamydial infection did not make it. And as for the ones that I have released, I cannot guarantee that these animals have been successfully rid of chlamydia, that they will not relapse nor transmit the infection to other koalas. Because of chlamydia, Australia is bleeding koalas. To try and stop the hemorrhage, this is what I do. Unfortunately, putting a band-aid on a hemorrhage is rarely a successful strategy. So I would like to conclude this presentation by quoting the wisdom of Sun Tzu, who 400 to 500 years BC wrote in The Art of War, "If you know the enemy and know yourself, you need not fear the result of 100 battles. If you know yourself but not the enemy, for every victory gained, you will also suffer a defeat. If you know neither the enemy nor yourself, you will succumb in every battle." And I think that sums it all well. Per our battle against chlamydia, we cannot successfully reverse the koala population decline caused by chlamydia if we don't understand the physiopathology of the bacteria, we don't understand the modes of transmission and the presence of reservoirs, we are uncertain of the efficacy of treatment, and we cannot better support koalas undergoing treatment and avoid dysbiosis. My take-home message for you today: the effective medical management of chlamydial infections, both at the individual and at the population levels, depends on the answers of these questions. So this is a call out to researchers and funding bodies. The need is urgent, and we're probably too late for some koala populations. We need to find answers, and at KCA we're keen. We have the koalas, We have the samples, we have the clinical expertise. Our actions and decisions have a direct impact on koala welfare and koala population health. We have lots of research project ideas and we're very keen to collaborate. So if you're interested, please reach out. And thank you very much for your attention today.